Hi, everybody. I am Dr. Shehla Shaikh, consultant endocrinologist from Sefi Hospital, Mumbai, reaching out to each and every one of you to wish you a very, very happy Ramadan 2022. It's an absolute pleasure being with all of you all today, and I am actually going to be talking to you about one of my favorite topics, and that is how to manage our type 2 diabetic patients during Ramadan. We all know Ramadan is the ninth month of the Islamic calendar, and this is the point of time when Muslims from all over the world would fast for 29 or 30 days, depending on the sighting of the moon. During this holy month, which is a month which is blessed with a number of spiritual benefits, the patients do not eat or drink anything from dawn, that is sunrise, till dusk, that is sunset. And subsequent to that period, the patients are allowed to eat and drink anything and everything that they do want to. Why is this different in our diabetic patients? What is it that makes it difficult for our diabetic patients who want to fast during Ramadan? Before I get into that, one very important fact that I would like to put across over here is that almost 76% of the patients do fast for at least more than 15 days during Ramadan. And a significant number of patients also insist on fasting throughout the entire month. When our patients decide to fast, it is now very, very important that we explain to them that they need to undergo a pre-Ramadan evaluation prior to Ramadan, at least 4 to 6 weeks prior to Ramadan, before the month of Shaban, or at least minimum 2 weeks before Ramadan, so that we are able to adjust the medications safely and we are able to help them fast much more easily than they would be able to do otherwise. The four most important complications that we do face as far as our patients are concerned during Ramadan are hypoglycemia due to the prolonged hours of fasting, hyperglycemia due to the increased calorie dense food that is eaten at iftar. Hyperglycemia is also seen as a result of significant reduction of medication, which a number of our patients also do on their own if they have seen as to what is done in the previous Ramadan, that is the Ramadan in the previous year. We do see a number of patients doing that also, which should be strongly discouraged because a patient's health can change between year to year. The third most important issue that can crop up can be diabetic ketoacidosis as a result of hyperglycemia. And of course, in tropical countries or in countries where there are long fasting hours, you can have potentially dehydration and thrombosis. The most important thing when your patient comes to you in your consulting rooms is, friends, that do they undergo a pre-Ramadan evaluation. A pre-Ramadan evaluation is now available on an app, very, very easily accessible, and is now based on a risk score system. Now, you would wonder, what is this risk score system and is it very complicated? Is it something that is going to actually take more of your time? You have a busy OPD, and now we are asking you to actually risk stratify each and every patient of yours who is walking in and is requesting you to allow them to fast during Ramadan. Actually, it's a very, very easy risk stratification score once you get used to it. It is as simple as this. This is something that we do very routinely in our consultings over here. This score is actually a score which is, most of it is filled by your diabetes educator or by your assistant outside your consulting. And the very, very important areas that you need to look into is the medication change. You need to look into the history, as far as especially history of hypoglycemia unawareness, and certain other parameters which would not take too much of your time. It is very important that we risk stratify our patients, because on the basis of this risk stratification, you are going to be able to understand whether this patient is at a mild risk of fasting. For example, if you look at this risk stratification score, you would see a score of 0 to 3 is a mild risk, a score of between 3 to 3.5 to 6 is a moderate risk, and a score more than that would be high risk. We are fortunate at this point of time that our clinician judgments and our scores are also accepted by the highest religious authorities. And why does this become very important, friends? This becomes very important is because When your patient falls in the high risk category and you tell the patient that it is advisable for you not to fast, the religious authorities also say the same thing. And when you have stratified your patient and told your patient that you are at high risk, you assume a great moral responsibility also as a clinician, that you are actually telling your patient that you are allowed not to fast. And that is the reason it becomes very important that we have used medical knowledge to the best of our ability to make a decision with the help of our patient together, and then have decided that the patient should not be fasting. I no longer believe that we are in a society where we can tell our patients what to do and what not to do. I believe it's a combined decision that you and your patient together take at the end of a conversation, and then you decide whether your patient can fast or not. When your patient is at the other end of the spectrum, if your patient is in the mild risk of fasting, you definitely can allow your patient to fast. I also face situations, to be honest, where my patients are in the mild risk of fasting and do not want to fast, and they will tell you, ma'am, I'm is it okay if I don't fast? You just told me I'm in the mild risk of fasting, I don't want to fast. And then as a clinician you may have to say, you can fast, but of course fasting is a personal choice, and whether you decide to fast or not is something you would decide. But yes, you do see people at both ends of the spectrum, though most of them will err on the side of saying that no, we want to fast. As far as the patients in the moderate risk go, those patients you can make individual decisions based upon what kind of evaluation you do clinically, what kind of laboratory parameters you get, what kind of history you are getting from your patient. For example, if your patient tells you that they've been having history of hypoglycemia, unawareness, they have repeated episodes of hypoglycemia, you would simply discourage your patients from fasting. That is something which is very, very important, because that goes in a very, very high risk of fasting. We also strongly discourage our pregnant ladies from fasting, because it comes not only in the high risk category, but also Islam does allow pregnant ladies the liberty of not being and of not fasting. And when the religion allows it, I tell all my patients, when you are fasting for the spiritual benefit, but at the same time if you're fasting against what the scriptures are allowing, then I think that is not the right way forward. Because at no point of time does any religion on planet earth allow you to harm your body. And that is a very important message we try to give across. Coming to pre-Ramadan evaluation, which we have started increasingly taking advantage of technology and are doing it on a number of platforms, because we have found that it is much easier for us to be able to not only talk to the patients but talk to families. We take whatever help we can. It may be from a spouse, it may be from a child. To be very honest, we also take the help of grandchildren, because we have all realized that grandchildren are very great at influencing their grandparents. So when nothing else works, we also take the help of grandchildren in this. And we take use these social media platform to reach out to our patients, to explain to them regarding certain very, very important parameters about Ramadan. Once we have finished with stratification, the three or four other very important parameters which I think the patient should be educated about are: when do they break the fast? That is another area of contention. Monitoring, another area of contention. Even now, even during this Ramadan, in spite of all the education that we are doing as clinicians, my patients will still, when I tell them to prick myself, always have that little bit of doubt on their face. Are you, madam, absolutely sure? Is it okay if we actually prick ourselves? And we reiterate that yes, your fast is not negated if you prick yourself. Withdrawing blood is allowed during fasting. Only taking in any nutrition is not allowed. And that is when the patient is convinced. We have now started telling our patients to be ambassadors and give this information to other people, even if they are not our patients, because we believe that one educated patient is an empowered patient, and this empowered patient does make a difference as far as society is concerned. I personally believe that Ramadan is an area of intermittent fasting and a period which could give us fantastic health benefits if it was not for the feasting at iftar. The biggest problem we have, friends, is the feasting. And whether it is a mindset, it is a social conditioning, it is a belief that you are blessed and the blessing, and of course, food is a blessing, and good food is a very, very big blessing. but high calorie dense food is not that much of a blessing for my diabetic patients. So we are increasingly trying to encourage them. We are sending them pictures of the Ramadan plate. We are encouraging them to increase their protein intake. Again, protein intake which is not deep fried, because that again can become detrimental. We are encouraging them to have non-sweetened beverages, be it local beverages, whichever local beverages. We are asking them to have infused water, because at least with that, patients feel that they have had something different other than just plain water. So we are trying to replace at least some of the beverages with a lot of other beverages which could potentially be healthy. One of the simple ways in which we've also tried to do this is tell our patients to have it alternate day. So at least one day we tell them, one day have a sweetened beverage with less of your sweeteners in it, and the other day have a beverage with absolutely no sweetener, have a non sweetened beverage. And we've found that it helps as far as the patients, I mean, mental well-being is concerned, because these are social occasions. These are occasions where groups sit together and open fast. These are occasions where it's a family, and families can be significant number of people could be sitting together and breaking their fast, because there are people who are invited across. And in that situation, when you tell a diabetic patient you cannot consume XYZ, it becomes very, very demotivating for the patient. And finally, I think we need to be a little more emphatic, we need to be a little more empathetic. And in that situation, we are teaching our patients that you first opt for the greens, you first opt for the proteins, you have your fruits, and then you opt for the fried high calorie food. And by then, and the second most important message we tell them is eat slowly. We tell them, I know you're hungry, your hunger pangs are there, and most of us will just gobble whatever is there in the plate in front. And that is the reason the satiety center is simply not aware that you've eaten so much. So we tell them, if you eat a little slowly, the satiety center would be stimulated. You would realize that yes, you have eaten significant amount of food and you can stop. And we also do this another trick in which we do it. We tell them, eat half your meal, then pray, and then eat the rest of the meal. So by the time the patient has come back to the second time, the patient is relatively feeling quite full. The patient is feeling that okay, they've eaten what is required, and then they tend to eat less. So we are trying every trick in the book, to be honest, to get our patients to eat more healthily. We also encourage the younger generation, the grandchildren, to encourage their grandparents and their parents to eat more healthily, and keep something like a point system where you get so many points if you've been so well behaved. And we sort of try to create games out of it, so that somebody is sort of at the end of the day, I mean, gifted something, so that they feel like, oh my god, I did such a great job as far as my diet goes, because it's something for a month we want our patients to be healthy. Having said that, when it comes to physical activity and fluids, we do encourage our patients, unless there's some restrictions of fluid, that you should drink as much water as possible from the time that you break your fast till the time you again, for sehri time, that is till the time you are again going to be restarting your fast. So we encourage them to keep their water bottles separately. Do not use water from a combined source, because then it is difficult for you to understand that actually how much water you have taken. So please keep your bottles separately, and see to that you are consuming sufficient amount of water. The Taraweeh prayer, which is said during Ramadan, is a significantly long prayer, and that is considered to be part of the activity that the patient does. But mind you, the calories which are actually burned in the Taraweeh prayer are only 80 calories. So you have to take that into account as far as your activity is concerned. And you continue doing your activity, but do it after you have broken your fast, so that there is no increased risk of hypoglycemia. Last but not the least, medication adjustment. It is very important that clinicians make medication adjustment 2 to 4 weeks prior to Ramadan. That is absolutely paramount, that that is done at the right time. Conventional medicines like metformin, glitazones, your alpha glucosidase inhibitors, GLP-1 receptor agonists do not require any adjustment during Ramadan. The two main molecules that require adjustment during Ramadan, friends, are going to be your sulfonylureas and are going to be insulin. So most of us are now using second generation sulfonylureas. And as we all know, if the patient is on a single dose, you would just switch the dose to evening hours. You would ask the patient to take that medicine at iftar. If the patient is on twice daily dosage, you would reduce the morning dose and you would ask the patient to take the entire dose at iftar. Or if the patient is very well controlled on HB1C, for example, of 6.5, 6.8, you may even knock off the morning dose, monitor the patient, and then individually decide whether you want to restart the same dose at suhoor, or maybe you want to start a shorter acting agent like a ripaglinite for suhoor to be able to uh, to be able to manage your patient's sugars during Ramadan. So there are many individual ways in which you can manage your patient during Ramadan as far as the second generation SUs go. As far as insulin is concerned, basal insulin, you would reduce the dose by 20 to 50%, depending again on the patient's lifestyle, what kind of intake your patient is going to have. And you switch the timing to around iftar, and that main reason you do it so that you reduce the potential anti-hypoglycemic effect of the medication just prior to opening the fast, that is from in the early evening hours. If the patient is on a pre-mixed insulin, the morning dose of insulin is switched to the evening hours, and the evening dose which you are giving your patient is reduced by 30 to 50% and giving in the morning hours. And that is how you would manage your patients. Basal bolus doses, if you are the patient is on, you would reduce the basal dose again by 30 to 50% if required. And the bolus, if the patient is on fast acting or ultra fast acting, you would give it in the morning at suhoor time and at iftar time. But all these friends would require close monitoring. So it is very, very important that you explain to your patient that the key to you fasting safely is you monitoring yourself, in you understanding how your body is reacting to the prolonged fasting, is in understanding how the feasting that you are doing, what kind of effect it is happening to your sugars, because it is finally your body, and we want your body to have no kind of ill effect at any point of time. Once the patient realizes that you are on the same side of the table, you have a very compliant patient who is willing to do the monitoring that is required. And if the patient is unable to or cannot do the monitoring, that almost becomes like a red flag, especially if the patient is insulin, because then it becomes much more difficult for you to allow your patient to fast. Last but not the least, the Eid, which is a 3 day period of festivity, again encourage moderation. Again, encourage that yes, we understand it's a festive occasion, but festivities can be celebrated not necessarily only with food, though all of us associate all kinds of festivals with food, especially in our country. Everything which is happy is associated with a lot of sweets, a lot of sweet beverages. But we do encourage our patients, we encourage our dietitians to reach out to patients and encourage them to have healthier beverages, healthier food, so with less oil, less with the less simple carbs, so that the Eid festival can be celebrated with the spirit of brotherhood rather than with a problem of hyperglycemia. I think that would be the last message which I want to give all of you all. Wishing each and every one of you a very happy, a very spiritual, and a very, very peaceful Ramadan. Thank you very much.